Boy, do I have a fun one for you guys today. Principles of Pharmacology. This is a little bit of a longer chapter. I'm going to try to cut through it as quick as I can while being clear and concise as possible. So let's just jump right into that. So the introduction. AEMTs can administer certain types of medications. You know, D10, IV Zofran, IV fluids, a whole bunch of other stuff. And you can also help patients self-administer other medications like their meter dose inhaler, their EpiPen. And a drug profile gives all the specifics about a kind of drug. Usually included on a package insert. Here's a package insert you might be familiar with. This is the 4 milligrams of Zofran that we see on those vials that are included in all of our Region 5 drug bags. You can also find it in pharmaceutical publications. There's a few of those online. You can look at the FDA does all this information. You can find it on Daily Med, Medline Plus. DEA might have some information on more illicit, illegal substances. So those are just places you can find those. So pharmacology, it's the study of properties and effects of drugs and medications on the body. So drugs and medications, those are a little different. Every medication is a drug, but not every drug is a medication. Drugs are substances that may have a positive or negative effect on the body, while medicines are mostly only intended for therapeutic use and positive effects. So illicit substances like heroin wouldn't fit the medicine category because it's just not pure therapeutic. It has negative effects on the body. Let's talk a little bit about dose. It's the amount of medication that's given. You guys should be pretty familiar with that term by now. Action. The therapeutic or intended effect a medication is expected to have on the body. Like Zofran, our action would be decreasing nausea, reducing nausea, helping vomiting. And there's some extra stuff involved here, unintended effects. Effects that are undesirable but pose little risk to the patient. Stuff like dry mouth and drowsiness, those would be unintended effects of a medication. Untoward effects are effects that can be harmful to the patient, like maybe an anaphylactic reaction. That wouldn't be too good. And toxicity. A risk that a substance will pose a health hazard to an individual or organism. Big medication when I think of toxicity is digoxin. Has such a narrow therapeutic window that it's very easy to get a toxic buildup of digoxin. Indications. You guys should also know this by now. These are the therapeutic uses for a particular medication. Why we give them in the first place. They have to meet some of our indications. And similarly, contraindications, we know these. This is why you should not give a patient a medication. Nitroglycerin, hypotension. Severe hypotension would be a contraindication for nitroglycerin because it lowers blood pressure and can harm our patient. So let's talk a little bit about medication names, starting off with finding out where drugs come from. They come from 4 principal sources. Animals. Heparin actually comes from the intestines of pigs. The more you know. Some drugs that come from vegetables or plants. Morphine and codeine. These come from the opium poppy. That is a plant. Minerals. Stuff like iron, mag sulfate. And then synthetic compounds like fentanyl. Fentanyl is 100% man-made. It is a synthetic opiate. Okay, so here's the fun stuff. Trade name. It is the brand name from a manufacturer. So let's talk about Zofran for a minute. Zofran is the trade name for the medication that goes by the generic name ondansetron. And the chemical name for ondansetron is ondansetron hydrochloride dihydrate. And that is a precise description of the medication's chemical composition and molecular structure. And there's also an official name, which is just the ondansetron hydrochloride. That's the name given by the USP, which is the United States Pharmacopoeia. And here's an example, and I'm not going to be reading all that because I don't know how to say it, and I'll embarrass myself. So take a look at that. I'll hold out here for just a second so you can read that. Now we're going to move on. So, prescription medications. These are distributed by pharmacists according to a physician's order. So, you go to the doctor, they say, oh, you need this or that. They'll write a script, send it to the pharmacy. You go pick up the pharmacy after talking to the pharmacist, and you're on your way. You need a script for those medications. Those are prescription medications. Over-the-counter medications are some you can just go in and grab yourself. Aspirin is over the counter. You can go to Meijer and walk over to the pharmacy area. You don't even have to go over to the counter. It's going to be on a shelf. You can grab it and go check out. No doctor script, no nothing. So sources of drug information. Like I said, the FDA kind of makes the drug information. So you can go to the U.S. FDA Center for Drug Evaluation and Research, physician's desk reference, hospital formulary, the drug inserts, and the internet. When using the internet, please make sure you are using properly vetted sources. There's quite a few out there, so they should be the first results when you look anything up. But always just double check your sources, make sure you're getting it from a reputable source. U.S. regulations of pharmaceuticals. So the manufacture of pharmaceuticals in the United States is subject to a variety of laws and regulations. Imagine that. In the United States, drug standards are published in the USP and the National Formulary. The National Formulary is a curated list of prescription medications, and it kind of ties in with the USP. They kind of work together, and their websites are kind of one and the same. Several federal laws have been enacted to protect patients from unsafe substances and unscrupulous manufacturers and distributors. There have been a whole bunch of laws about false advertising, and they crack down on that. So if you claim a drug does something that it doesn't actually do, they're kind of on your case. We'll talk about a few different legislations that are involved with drugs. The Pure Food and Drug Act of 1906. This protects the public from foods, medications, and alcoholic beverages that may be mislabeled, poisonous, or otherwise harmful. In the Food, Drug, and Cosmetic Act required drug makers to include warnings about habit-forming substances and possible side effects. The Harrison Narcotic Act of 1914. This regulated the import, manufacture, prescription, and sale of several non-narcotic drugs and cocaine, opium, and their derivatives. And the Narcotic Control Act, about 42 years later, in 1956, increased penalties for violation of the Harrison Narcotic Act and made heroin and marijuana illegal. Next, we have the Controlled Substances Act of 1970. This is a comprehensive legislation dealing with narcotic and non-narcotic drugs that have potential for abuse. It specifies registration, procurement, storage, distribution. You need record keeping for these drugs, and there will be penalties if you were to fail to comply. So, manufacturing-related regulations. Federal legislation also focuses on guaranteeing standardization of doses. For a drug to carry the United States Pharmacopoeia label, the amount of active ingredients must be within 95 to 105% of that stated on the label. So which government agencies regulate drugs? The FDA, which is the Food and Drug Administration. The DEA, Drug Enforcement Administration, is also big on it. Public Health Service, and the Federal Trade Commission. So let's go through the drug approval process. So science is making some breakthroughs. They discover something new, and they want to get it out on the street to help people. Unfortunately, commercialization process, it takes a few years. Manufacturers sometimes discover the drug dose does not work as envisioned or might be too dangerous. They might have had success with the first few patients, but if they ever got to a clinical trial with, say, 100 people, half of them might drop dead. All new drugs must go through animal studies and clinical trials in humans before approval for distribution. You hear about this often. Sometimes you hear news articles about how they cured cancer in mice, and they might be moving to human trials very soon. Clinical trials. So there's 4 phases that they go through. Phase 1 is the new drug is tested in healthy volunteers. Phase 2, it's performed in a homogeneous population of patients. So it's a bunch of patients that share similar health problems or are relatively healthy. Phase 3 is the drug is made available to a larger group of patients, so we're just increasing our clinical group size. And phase 4 is the application to FDA for approval to market the drug. So, how are drugs stored and what security is in place? So, drug containers should be guarded against possible theft. That is why all of our ambulances have locked drug cabinets. If controlled substances are administered, records must be kept separate. That's why we have the little, in the NARC sheets we have to sign and trade in with pharmacy. And expired controlled medications must be destroyed. That's not really our wheelhouse. We turn it into pharmacy and they take care of it. I included a little graphic here of the Stryker cactus. It's a smart sink. It's sometimes what they use in the hospital to get rid of controlled medications. They'll just pour it in there and it cannot be retrieved out, and then it will be disposed of properly. So, potency of medications is affected by temperature, light, moisture, shelf life, and exposure to air. All of you have seen the nitroglycerin bottles. As you can see, they have an amber tint to them. That is to prevent the sunlight from getting in there and biodegrading the nitro. I've included a little picture here. There is the nitro. You can see it's dark in color. It's to keep the light out. It also doesn't do well with exposure to air, so don't leave your nitro tablets open. Obviously, shelf life. They can't last forever. They will expire at some point. So let's talk about some special considerations. As far as special considerations go, pregnant patients are usually at the top of the list. If you're giving medications to any female, I would ask if they're pregnant. Always expect the benefits of a drug to be considered against the possible risk. There are a few different categories. The ones we need to be concerned about are categories D and X. So category D drugs are the fetus will be harmed by the administration of a drug, but you can give it if the benefits outweigh the risks. So if it's a life or death situation and the mother needs it, go ahead and give the medication. We can deal with the rest later on. ACE inhibitors are going to be in category D. Then there's category X, and X is contraindicated. Under no circumstances should you give these medications to pregnant patients because the risk for the fetus just far outweighs any benefit you could have. Some of the drugs that are involved in this are the statins, the torvastatin, and like warfarin's also in there. These are just drugs you will not give. Changes in pregnant women's body affect the way drugs are processed. Also, the placenta is not very good at filtering out drugs, and the drugs can go straight into the unborn child, and they can develop addiction before they're even born, and then they can have withdrawals as soon as they're born, and it's just a whole mess. Delay pharmacologic treatments for pregnant patients until they reach the hospital, unless you really need to. It's just safe to not risk it. When in doubt, contact medical control. They will have your back. Give them a call at any time. Pediatric patients. Medications have different effects on children, especially younger infants. They have a reduced metabolic capacity. Some of their kidneys or their liver isn't fully developed yet, and these medications may not be fully processed by their body and can cause some toxicity issues. However, they can also metabolize medications quicker than adults sometimes. So you might need to consider smaller doses over longer periods of time for something like pain medications. Consult your MyMedic cards. That's what they're there for. And our biggest population base, geriatric patients. As we get older, our hepatic functions kind of go down. Gastrointestinal activity slows. Absorption and elimination, all these things are going to slow down. They're also big fans of polypharmacy. A lot of older patients are taking a bunch of medications. You've all seen it, the pill bottles scattered around the house. They have a whole bunch. They can't even tell you how many they're taking. Or they have sheets upon sheets of different meds that they're all taking right now. These therapies may interact and modify the effects of each medication. It's like a game the doctor has to play to make sure all the drugs work together with one another. And that's just kind of way above anything that we can try to figure out. Scope of practice. Kind of leaning back into our med legal stuff. You are legally, morally, and ethically responsible for each drug you administer. Imagine that. The drug administration must be safe and therapeutically effective. And always keep a field guide or other reference handy. If you don't have it, download the PPP Agency app with all the protocols on it. It is very effective, very good. It has all of your drugs in there. It has your MyMedic cards. It's something you're going to want to have. Trust me on that. Methods of drug classification. These are based on effect drugs have on a particular part of the body or specific condition. They are classified into 3 categories: body system, class of agent, and mechanism of action. And we're going to talk a little bit more about those. So let's talk about nervous system classifications. The body's principal control system, composed of the CNS, the central nervous system, and the peripheral nervous system. The peripheral nervous system includes all of the nervous tissues outside of the CNS, which is the brain and the spinal cord. Contains the autonomic nervous system, the ANS, and the ANS is divided into sympathetic and parasympathetic nervous system. And we'll talk more about those. Hormones released by sympathetic system stimulation act on hormone receptors. So, as we know, the sympathetic nervous system is fight or flight, and adrenergic receptors cause a response in the target organ. Here are the 4 different types. So we have alpha 1, that's going to be our vascular smooth muscle. It's going to be vasoconstriction. Alpha 2, that's going to be also some vascular smooth muscle. It's going to have some sedation effects. It's going to relax some of your muscles. Beta 1, that's going to be your heart and your kidneys. And beta 2 is going to be your lungs. The way I remember it all the time is beta 1, you have 1 heart, and beta 2, you have 2 lungs. Drugs affecting the sympathetic nervous system. We have sympathomimetics. These mimic the effect of the sympathetic nervous system. So can we think of any drugs off the top of our head that would mimic the effects of the sympathetic nervous system? Fight or flight. Adrenaline, amphetamines, dopamine. Those are all sympathomimetics. Sympatholytics inhibit the sympathetic nervous system. These are also known as anti-adrenergics. So a few of those would be alpha blockers or beta blockers. Let's talk a little bit about antagonists. So an antagonist is something that counteracts the action of something else. Like Narcan is an antagonist for opiates. Agonists are medications that bind to a receptor and cause a response. So in the same way, an opiate is an agonist because it binds to a receptor and causes a response. Talk a little bit about beta blockers too. So these are used to control blood pressure in some patients and heart rhythm disturbances in others. Because it's blocking the beta receptors, it's not going to have our heart beating as fast. Beta 2 selective drugs cause bronchodilation with little effect on the heart. Some beta 2 drugs are albuterol. So now we're going to move on to the parasympathetic nervous system. Parasympathomimetics are agonists to the parasympathetic nervous system. These are also called cholinergic medications. If you have excessive cholinergics present, the patients may exhibit sludgem symptoms. And if you remember, sludgem is usually associated with things like organophosphate poisoning, fertilizers, all that other stuff, sarin gas, because it could cause a buildup of acetylcholine, which is cholinergic. And for those of you who don't remember, sludgem is salivation and sweating, lacrimation, urination, defecation, gastrointestinal upset, emesis, and muscle twitching. Parasympatholytics. So these are antagonists to the PNS, also called anticholinergic medications, atropine being one of the most commonly used ones. So when we think of parasympathetic nervous system rest and digest, we think of a lower heart rate, and we give atropine for bradycardia because it's working against the parasympathetic nervous system to increase our heart rate. And also, for those of you who may or may not know, atropine is about one of the only drugs we can give for organophosphate poisonings because it's an anticholinergic and it's working against the cholinergic buildup from organophosphates. Oh boy, analgesics and antagonists. So, analgesics are medications that relieve pain and induce analgesia. Opioid agonists are similar to or derived from the opium plant. Morphine, codeine, and CNS depressants. So let's talk about some non-opioid agonists. They will have some antipyretic properties, and they alter the production of prostaglandins and cyclooxygenase. Salicylates like aspirin. We have NSAIDs like ibuprofen, paramphetamol derivatives like acetaminophen, and let's talk about some opioid antagonists. So these reverse the effects of opioid drugs. So, like I said earlier, naloxone. Naloxone is going to knock these opioids out of these receptors. It's going to block them. And it's taking up, when it's sitting in these receptors, the opioids cannot act on them. And therefore it is working against. It's an antagonist, stopping them from working. Opioid agonist antagonists are very interesting. A lot of you may have heard of Suboxone at this point. It's a medication they give those who are trying to get off opiates because they have agonistic and antagonistic properties. It can decrease pain but not diminish the function of the respiratory system. So the way it works is it partially acts on these receptors. So it provides some of the pain relief, but it has a ceiling. It can only affect so much, but it doesn't decrease their respiratory status at all. It also has Narcan mixed in with it. And so if they try to snort it or inject it, it immediately kills the high. It only works if you take it under the tongue, which is the way they want it to, because naloxone doesn't work through that route very efficiently. So we're going to talk about some anti-anxiety, sedative, and hypnotic drugs. So this helps a patient sleep through a medical procedure by producing sedation and hypnosis. Drugs that create sedation and hypnosis are benzodiazepines, barbiturates, opioid agonists, non-barbiturate hypnotics, and dissociative anesthetic agents. So these can have a lot of side effects. Anticonvulsants, used to treat seizures, believed to work by inhibiting the influx of sodium into cells. The belief is decreasing the cell's capability to depolarize and propagate the seizures. Stimulants. These excite the central nervous system, increase excitatory neurotransmitters, and decrease inhibitory neurotransmitters. These increase the release of dopamine and norepinephrine to increase wakefulness and awareness, like caffeine and cocaine. High doses can cause increased nervousness, irritability, tremors, and headaches. And some of you know that we can also have withdrawals just from stimulants. I'm sure a few of you may have caffeine addictions, such as myself, and if you don't have it for sometimes even like 10 hours, I start getting headaches. All right, depressants. These are downers. These slow the brain activities. They may be prescribed to treat anxiety, muscle tension, pain, insomnia, stress, panic attacks, seizures. Some depressants are used as anesthetics. Here are a few of them right here. Lorazepam, or you may know it as Ativan. Diazepam, also known as Valium. Alprazolam, which is Xanax. Also Pidem tartrate, which is Ambien. Psychotherapeutic drugs. So these block dopamine receptors in the brain, and it's used to treat illnesses such as schizophrenia and depression. You can get a lot of symptoms like involuntary movements, tremors. There's rigidity, muscle contractions, restlessness. You may have changes in breathing and heart rate. Orthostatic hypotension can also be present. and there may be some sexual dysfunction. Depression is often treated with SSRIs, monoamine oxidase inhibitors, and the TCAs, the tricyclic antidepressants. So here's some fun stuff. Drugs affecting the cardiovascular system. So effects on the heart can be positive or negative. Chronotropic is the heart rate. The Greek deity known as Kronos is the personification of time, so how many times the heart beats. Inotropic is the strength of your contraction of the heart. And dromotropic has to do with the speed of electricity being conducted through the heart. Cardiac glycosides are indirectly increase calcium concentrations. We mentioned digoxin earlier. That is a cardiac glycoside. So some antiarrhythmic medications. These can have direct and indirect effects on cardiac tissue, like sodium channel blockers. So sodium channel blockers slow the conduction through the heart, and that's a negative dromotropic effect. Beta blockers, we talked about, reduce the adrenergic stimulation of beta receptors, beta 1 and beta 2. Potassium channel blockers, this increases the heart's contractility, which is positive inotropic. And calcium channel blockers, which decrease the force of contraction and automaticity and decrease conduction velocity. So that's a negative dromotropic effect. Antihypertensives. Diuretics cause kidneys to remove excess amounts of salt and water. Vasodilators act on smooth muscle of arterioles and veins. Sympathetic blocking agents diminish effects of beta stimulation. And angiotensin converting enzyme, or ACE inhibitors, target the renin-angiotensin aldosterone system. I'm sorry. So anticoagulants, fibrinolytics, and blood components. Antiplatelet agents interfere with the aggregation of platelets, which is the forming together. Anticoagulant drugs work against coagulation to prevent the formation of thrombi, which you know are clots. Fibrinolytic agents dissolve a thrombus and prevent it from breaking off and entering the bloodstream, stuff like TPA. Now we're going to talk about some drugs affecting the respiratory system. So, oxygen is a medication and has appropriate and inappropriate uses and side effects. We often forget it, but yes, oxygen is a drug. Many respiratory emergency treatments use sympathomimetic medications, like we're talking about the beta agonists and the epi and all that other stuff. They mimic the sympathetic nervous system. Xanthines relax smooth muscles of the bronchioles and increase blood flow. And corticosteroids suppress the inflammatory response. Xanthines are kind of a secondary medication. They are kind of what chronic COPD and chronic asthma patients take daily. More like an oral pill sort of thing. So drugs affecting the pancreas. Variety of hypoglycemic medications are available. Some act on the pancreas directly. Others alter the way insulin is used by the body. Sulfonylureas increase insulin secretion from the pancreatic beta cell. Insulin sensitivity is increased by oral hypoglycemic agents. Drugs affecting the immunologic system. Immunosuppressant medications are often prescribed to patients who undergo an organ transplant or have an autoimmune disease. And right below we see why. We want to inhibit the body's ability to attack a foreign organ. Sometimes during organ transplants, your body may not recognize the new organ that's been transplanted into you, and your body will actively try to destroy it. So we're going to want to stop that whole process by taking immunosuppressant medications. Autoimmune disease, your body attacks itself via the immune system, so immunosuppressants will stop that. Vitamins and minerals. Oh boy. Necessary substances that allow for normal metabolism, growth and development, and cellular function. Some of you may take vitamin supplements. They can replace deficiencies or just as a preventative measure. Thiamine is important in the pre-hospital setting. For patients who have alcoholism, they tend to be deficient in thiamine, and they may devolve into Wernicke's encephalopathy, which is a very, very severe acute neurological emergency due to the lack of thiamine in the body. So here's kind of an important topic to know, since AEMTs, you now have access to intravenous fluids. So crystalloid solutions are typically used in the pre-hospital setting due to their cheaper cost compared to colloids. And what is a crystalloid solution? So a crystalloid solution is a solution that has small particles, kind of like electrolytes, like salt, so that would be like saline, or maybe something like sugar in there, so like your D10s or D50s and all that are going to be crystalloid solutions. They replace fluid quickly as compared to their colloids. Colloids use larger particles like proteins and starches, and the fluid kind of remains inside the vessel instead of being distributed. Crystalloid solutions come in 3 different flavors, so to say: isotonic, hypertonic, and hypotonic. So we'll start with isotonic. Isotonic is the most common. 0.9% normal saline. That is isotonic because it has the same concentration of solutes that's present in the cytoplasm of the cells in the body and the blood. It's a stable medium for medication administration. It's effective for electrolyte replacement. And we'll talk more now on hypertonic. So instead now of matching what's inside the cells, hypertonic has a higher concentration of solutes and less water. So this means when it comes in contact with the cell, the process of osmosis occurs. So the cell is going to take water out and try to add it to the solution, kind of drying out the cell a little bit, because it wants to stabilize the solute heavy solution. Hypertonic salines are most commonly going to be seen in cerebral edema, because the hypertonic saline, when it enters the brain, it's going to pull the water from the cells up there because of this osmosis, and it will reduce the ICP and cerebral edema. Hypotonic is the exact opposite, where it's a lot more water than solute, and this causes water to leave the solution into cells, and this can help with intracellular dehydration. Keep in mind this is beneficial for dehydration, but not exactly hypovolemia. In dehydration, your cells have a lack of water. It's not entirely a lack of fluid per se. Yep, like I said, you can also administer colloids, but we don't have any, and they're very expensive. Drug forms. So these are the forms of medication that they come in, and usually the form it's in will determine how it's administered. So this ensures proper route for the medication, timing of its release into the bloodstream, and effects on the target organs or body systems. So some solid drugs are capsules, tablets, pills, or suppositories. Liquid drugs, solutions, suspensions, tinctures, spirits, elixirs, syrups, and emulsions. MDIs, metered dose inhalers. You have probably seen a few of these in our time. Miniature spray canisters used to direct substances through the mouth and into the lungs. Commonly used by patients with respiratory illnesses, usually an albuterol or something similar. They should deliver the same amount of medication each time they're used, and they must be shaken vigorously before being used, because sometimes it's the suspension inside of the medication itself. Topical medications applied to the surface of the skin, and they affect only the area they've been applied to. Stuff like lotions, creams, ointments. Transcutaneous medication, transdermal patches. There's an image of that right there. Designed to be absorbed through the skin, usually intended for systemic effects. You usually see fentanyl patches, nicotine patches. They have nitro patches as well. If you're ever doing an assessment on a patient, be sure to ask about the patch. Gels, semi-liquid substance. administered orally through capsules or plastic tubes. Has the consistency of pastes or creams, and they're usually transparent. Gases. Oxygen being the most common one. The ones that aren't oxygen are usually delivered in an operating room. Stuff like nitrous oxide can reduce pain by being administered through a mask. So let's talk a little bit about routes. Routes affect the rate of onset of action. Enteral drugs are administered along any portion of the GI tract, either starting in the oral or starting on the other end at rectal. As far as rectal medications go, there are no AEMT medications that can be administered rectally, but there is a possible exception of D50 being allowed by local protocols to be administered rectally. So contact your local MCA if you want to do that. Parenteral medications are administered through any route other than the GI tract. So pretty much every other route: intravenous, subcutaneous, intramuscular, interosseous, giving it through the bone marrow, sublingual or buccal, transcutaneous or transdermal, intranasal, or inhalation. And now we'll talk about the glorious pharmacokinetics, the study of metabolism and actions of drugs. So all drugs go through 4 phases: drug absorption, which is the drug entering the body, drug distribution, and then biotransformation, which is the chemical alteration that a substance undergoes in the body. Usually the liver is responsible for biotransformation. And then the drug goes through elimination. Some of the organs that it can be eliminated through: the kidneys, the intestines, the lungs, the sweat glands, the mammary glands. If your excretion organs are damaged, you may find buildup, and you might see drug toxicity as a result. Pharmacodynamics, a way in which a medication produces the response we intended. Also includes factors that may alter the intended response or any side effects or unexpected effects. So, the mechanism of action. This is the big one. This is understanding how the drug works as a whole. Drug must reach appropriate concentrations at its site of action. Magnitude of response depends on dose and time it takes the drug to travel in the body. After the medication is bound to the receptor site, it initiates a chemical change that produces the expected effect. Drug-response relationship correlates the amount of medication given and the response it causes. When administering a medication, know the onset of action, the duration of action, and the termination of action. Some drugs take maybe 5 or more minutes to start kicking in. It's important to know that when looking for a change and seeing if your medication actually works. Duration of action. This is kind of big for pain medications. You want to know how long they're going to be good for. If you have a long transport time, you might want to consider additional doses. And termination of action is just when you no longer have a therapeutic effect. The therapeutic index is the ratio of a drug's lethal dose for 50% of the population to its effective dose for 50% of the population. To loop back to Johannsen for the 90th time, the therapeutic index was so slim. So the dose that was lethal for 50% of the population was very, very close to the effective dose for 50% of the population. Factors influencing medication interaction. Interaction between medication occurs whenever a drug is modified by another prescription medication, herbal or OTC medication, nicotine from cigarette smoking, something in the diet, or anything to which the patient is exposed. So we have some predictable responses, things that we want to happen. So like if we give Zofran and their nausea improves, that is a predictable response. That's what we're looking for. Iatrogenic responses are adverse condition inadvertently induced in a patient by the treatment. And then we have unpredictable responses. These are adverse effects that are not anticipated. So we have a whole bunch of different ones here. So serum sickness is a delayed reaction or hypersensitivity similar to an allergy. And we also have allergy there. Idiosyncrasy is a completely unique response specific to that person and is not seen in other patients. So you in particular might take a drug and it affects you in such a way that it doesn't affect anyone else. That would be considered an idiosyncrasy. Tolerance. Decreased response to the same amount of medication, often requiring higher doses. So if you take a drug enough, you might build up a tolerance and you might take more. Cross tolerance is another one in there, which is a tolerance to other drugs in a certain class as a result of prolonged administration of another medication in the same class. Say you take enough beta agonist inhalers and your doctor tries putting you on another one and it doesn't work because your body has developed a tolerance to beta agonists as a whole. It can also be seen, it's mostly seen in patients with pain medications. So if they become used to some opiates, then the other opiates might not work as well either. Drug dependence can occur. We don't want drug dependence. Drug interaction, they interact with other drugs. Habituation is a physical tolerance of and a psychological dependence on a drug. Drug antagonism. One medication blocks the body's response to another medication. So how do we reduce medication errors? Well, on our EMT portfolio day, I asked you about the patient medication rights. There's a little more than 5 here. This is more like big doctor stuff here, but use the rights of medication administration, such as the right patient, right medication and indication, right dose, right route, right time, right patient education, right to refuse, right response and evaluation, and right documentation. That's 9 right there. So how do we reduce medication errors? Using a current reliable medication reference source. So use your protocols, the new ones. Don't look at some of the old protocol binders that are left around station and expect those to be current medicine. Medicine is changing constantly, so always be ready to see new changes in the protocols. And always cross-check with your partner. Confirm the volume in a syringe, or just verbally confirm the dose with them. Always cross-check with your partner. And this lady looks like she has some severe edema of her tongue here. That's kind of obstructing her airway because she might have gotten a drug she was allergic to because we didn't do our rights and check her for allergies or anything like that. We can also evaluate for hypersensitivity before each medication administration. The Institute for Safe Medication Practices has developed a list of medication abbreviations prone to causing errors. That's what that giant thing in the corner is for over there. It's basically saying don't use some of the outdated medication symbols, like how micrograms was like the UG. Don't use that. Just say microgram or MCG. It's got a whole bunch of stuff in there. If you want to look it up on your own time, you're more than welcome to. Specific medications. An AEMT is allowed to administer or help patients self-administer numerous medications. And administer medications only if a licensed physician gives you a direct order or local medical protocols permit you to administer that medication. And that concludes our drug lecture. If you have any questions, don't hesitate to reach out. You can also read through the ebook and some other things. Thanks for sticking around. Sorry this video was so long. Catch you on the next one.